All right, it's go time. Welcome everybody to ASH 2025 Friday Symposiums, and thank you all for joining us here for tailoring bispecific antibodies to individualize relapse refractory follicular lymphoma care. And we will do this through the lens of a case-based discussion. So for all of you who joined us early, you should have already done this. For those of you who are coming in, please pull out those phones, those iPads, or whatever devices, and please use the QR code to join, to either view the slides, access today's content, ask us questions. Yes, right here, I have a device that I can see your questions. If you want, if they're burning, I will go through them, as long as they're appropriate, of course. Participate in polling questions. You can see that the Wi-Fi network is right here, and the password is hematology. All right, I should have stalled enough for all of you in the audience to have done this. All right. So I'm Matt Lunning. I'm from the University of Nebraska Medical Center, where I am our chief of hematology, as well as our medical director of gene and cellular therapy, and a lymphoma 100% of the time physician. And I'm joined by my international colleagues. We have an international crew today. Their bodies are on stage. What time zone their minds are in. We're going to be challenged today because we are spanning the globe all the way from Australia to Spain. And I will go ahead and let Dr. Chia introduce himself.
Yes, that's right, Matt. I try not to think about what time zone I'm actually in, but my name's Chan Chia. I'm a professor of hematology at St Charles Gairdner Hospital in Perth, Australia. It took me 32 hours to get here, but I'm delighted to be here.
He actually said, how many articles did you review? Do you count your 32 hours and like I reviewed 8 articles?
I think it was 6 manuscripts.
6 manuscripts.
Yeah.
Impressive. That's a slog right there. All right. And Ms. Bolaños.
Yes. My name is Natasha Bolaños. I'm the head of membership and alliances at Lymphoma Coalition. I will be providing the patient perspective, and I'm based in Madrid, Spain.
This is an interesting curveball that you all are going to get to experience today, because the data that she's going to show us is a global data set. And I think that this is going to be very interesting to get the patient caregiver perspective as we see a disease like follicular lymphoma, which is a marathon, not a sprint from a non-Hodgkin's lymphoma standpoint. All right, so I said we were going to do this from the lens of the patient case experience. We have 3 cases today. We have the younger patient with follicular lymphoma choosing second-line and later therapy. We'll then go to the second case, which is an older patient with relapsed refractory follicular lymphoma who experiences cytokine release syndrome in their home and is asking them the questions of what are some of the long-term bispecific side effects. And then our third case, which is a long-distance patient for a person who serves not only the rural, but also frontier communities with follicular lymphoma. This is really meaningful to me to have this discussion because we need to work our way through bispecifics from a long-distance standpoint. How do you manage access and other logistical challenges? We will then go through future directions and data updates, and then there will be a smattering of opportunities here for audience question and answers, again, through your devices up to me on the iPad. All right, so we're going to exercise those thumbs this morning. Are we ready? So how familiar are you with bispecific antibodies? In lymphoma, little to no experience. In lymphoma, moderate experience. Other malignancies, little to no experience. Other malignancies, moderate experience. Or I use bispecific antibodies routinely. We'll see if there's music. Is there music? Otherwise, I sing, I dance. All right, so here we go. It looks like next time I get to sing and dance. So we have about a third of the audience here today having little to no experience, some with moderate experience in lymphomas, very little, even though there are now bispecifics entering into small cell lung cancer as well as other solid tumor malignancies, and about 16% of us are using bispecific antibodies routinely in their practice. All right, so we are going to key in on follicular lymphoma today. Again, our most common indolent non-Hodgkin's lymphoma across the world. And here are some updates on where bispecific antibodies live as of December 2025. So epcoritamab, we know, has been approved since 2023. And at this ASH, we will see some emerging data with the second-line combination of epco plus lenalidomide and rituximab, or epco R squared. We know that epco is given third line as a monotherapy. It is delivered as a subcutaneous injection, and at least at the time point for the third line, it was designed to have unlimited therapy or time indeterminate therapy until progression and tolerance, or the patient says, I don't want to do this anymore. Pivoting to the middle, mosunetuzumab was approved for follicular lymphoma in 2022 as third-line follicular lymphoma. It is given as an IV administration. It's being studied as a subcutaneous administration. This is a fixed duration therapy for up to 17 cycles. You may stop a little bit sooner if those patients achieve a complete response. Odronextamab, or Odro, is currently not FDA approved in the United States. However, it is approved in the EU in 2024 for relapsed refractory follicular lymphoma. So I'll pivot here to Ms. Bolaños, and she'll tell us a little bit about the global patient survey that her and her colleagues did.
Yes, this is just to let you know that all the information that I will be providing today is based on evidence. Lymphoma Coalition is a global network of over 90 patient organizations from over 55 countries. And we run the Global Patient Survey online every 2 years. We have been doing that since 2008. And this is the largest global patient survey on lymphomas and CLL. The data I will be presented today is from 2024. We will be launching the next in January 2026. And we had overall 11,170 respondents, including patients, more than 9,000, and the rest are care partners. And just for you to know, we did a data pool with the patients living with follicular lymphoma, and we had over 167 patients with one relapse that will illustrate one of the cases, and over 230 patients with more than 2 relapses. And the survey is offered in 20 languages, and we got responses from 79 countries in 2024. And we normally use this data to drive change in policy making, in clinical decisions. We provide information for clinical guidelines, practice, and so on. So hopefully it will be an eye-opener for you as well.
You are getting a special treat today to see this data set and actually get to hear from somebody who participated in kind of aggregating this data and really walking us through it. Perhaps you can walk me through how patients actually got access to this. Is this something that they saw as a sticker on the train, or is it in the clinic, or how did they come to getting access to this survey?
Well, the drivers of the Global Patient Survey are our member organizations, and they have several strategies to go through that. As the survey covers all the dimensions from diagnosis to end of life, it's quite comprehensive. Of course, they get in touch with the healthcare professionals to try to promote at the clinic and also at community hospitals, sometimes also in primary care, because there are patients that still are engaging with those. But it's also promoted, of course, online, through websites, through social media channels. We also do a lot of promotion ourselves. And there are many members that, because access to online platforms may not be so readily available depending on the country or depending on the characteristics of the patients, they also print copies, and they provide the printed copies to nurses and to the clinics so they can also go through. They also make telephone calls so they can go through the entire survey over a conversation, and they can connect with the patients but also with the care partners, because the differences may be slightly different even in the same experience. And so that's how we promote.
So
basically,
very robust, very robust, very
yeah.
longitudinal experience here.
Yeah.
So
Yeah.
it will be great as she will go through some of her some of the data here for our follicular lymphoma patient population. Awesome. All right, this is just another teaser. So as your neurons get tickled up by us up here, feel free to send in questions during the program by scanning the QR code. All right, so we're going to go right into our first case, which is our younger follicular lymphoma patient, for him who's choosing second line or later therapy. All right, so this is Joe. So Joe is a 45-year-old man. So for those of you who know follicular lymphoma, right, this is 2 decades too early, right, if you look at median age of diagnosis. So this is something that is uncommon, but certainly does happen in follicular lymphoma. Joe is married. He has 2 young children. He lives within 30 minutes of an academic medical center. He works full time. He has a supportive spouse who travels for her work. Now, Joe was diagnosed 4 years ago. So he may be 45 now, but he was 41 when he was diagnosed. He had at a period of time, like many patients with follicular lymphoma, where we really tried to learn about his disease through the lens of active surveillance, right? So he did not have initial indication for therapy, and he underwent a watch and wait or an active surveillance approach. However, over time, at about 2.5 years, he did have progressive disease, as manifested like many patients with stage 4 disease. He had B symptoms. He was mildly anemic. His LDH was elevated. His bone marrow was involved, but he still had less than 4 nodal sites of disease. But he was classified as FLIPI high risk at the time of needing his therapy. Now, I can tell you that an expert lymphoma doctor evaluated his care because that individual was sitting up on stage with me. That would be Dr. Chia here. And so you can guarantee that he did the thorough workup, making sure that Joe did not have transformation of his follicular lymphoma, which is an incredibly important aspect because that would be potentially practice changing in what you would offer this individual's first-line therapy. So that did not happen, but this patient had symptomatic follicular lymphoma. He underwent BR for 6 cycles, obtaining a metabolic complete response. He chose not to do maintenance rituximab and enter into further follow-up. Unfortunately, at about that 18 months after the completion of the BR, he presents now to our clinic with abdominal pain, night sweats, and unintentional weight loss, telling you that this is exactly how I felt when I was in need of first-line therapy. He tells you, as we should be doing in a matter of shared decision-making, that he remains well, but he is having symptoms. He remains fully engaged with his family and professional responsibilities and wants to continue to do that because he's 45 years old. But he also wants you to think about him not only for now, but that from a life expectancy, an actual life expectancy, he's still thinking about 25 years or plus of life. And how are we going to get him there with his follicular lymphoma? So our first question is, are we starting therapy now? Yes, no, or you're not sure?
We've got the music now, Matt.
Oh, I got the music, all right. We're in the club. Not quite Night at the Roxbury, but. All right, so 71% of you said yes, some no's, and some unsure. So, Chan, what are your thoughts about kind of starting therapy for this individual?
Good question, Matt. I think that we have clearly established criteria for the initiation of therapy in patients with follicular lymphoma, so-called GELF criteria, and essentially it means disease symptoms. And we most commonly apply this in the first-line setting. However, it's also known that at the time of relapse, many patients are asymptomatic at the time of relapse. And as you alluded to initially, the management of these patients is a marathon, it's not a sprint. And if patients have asymptomatic relapse, they do not require therapy. However, Joe has symptoms pretty clearly. He's got fevers, he's got sweats, and it's someone who does need to be treated now.
So thinking through his case, just like you did when he was first needing treatment. He
Right.
had symptoms from that standpoint. How would you approach trying, now in the relapse setting, right? He went into remission. How would you reassess his disease status from the standpoint of choosing his next therapy?
It's a good question, and I think one thing that you highlighted during his case presentation was the time of, or the duration of his first remission, and he experienced lymphoma relapse 18 months after bendamustine rituximab, which, as we know, is a adversely prognostic thing. It's a so-called progression of disease within 24 months, or POD24 event, and multiple data sets have now instructed us that patients who experience POD24 events are unfortunately likely to have adverse outcomes with subsequent chemotherapy at least. So I think that is one consideration. His age and his fitness are also considerations, because the treatment options which are relevant to someone like Joe, who's 45 years old, are quite different to someone who's in their 80s, for instance. And to take into account what his particular life goals are. He's got 2 young children, he's still working, and thinking about what impact your next decision or shared decision about therapy has to take into account what his needs and preferences and values are, and those are all relevant things, I think.
Yeah, I think that when I hear about POD24, in my mind, it's a shot over the bow that this is probably going to be a lymphoma that may impact his long-term survival.
Right.
From that standpoint, comparatively to those patients who relapse beyond that two-year mark. And if you go all reflecting back now almost a decade to the original POD24 Casulo JCO paper around this topic, has workup changed at all? Are you still doing PET scans? Are you still biopsying these people? Are you just saying it's obviously follicular lymphoma?
No, it's a leading question, but you're absolutely right. And patients who experience early progression with bendamustine rituximab, as illustrated nicely by the Vancouver group, there was a high proportion of those patients actually had transformed disease at the time of progression. And repeat PET and a biopsy of ideally the most FDG-avid site, if it's at all practical, in order to confirm that this patient does in fact still have follicular lymphoma and not transformation to diffuse large B-cell lymphoma, is critically important, because the treatment obviously is substantially different whether a patient has got transformed disease at this point or whether they have in fact relapse of their follicular lymphoma. So really important to establish.
Yeah, no, I often talk to my patients about Sesame Street in these situations, because when I do a PET scan, I'm often looking for the Sesame Street lymph node. Which one of these does not look like the other, right? And PET scans actually can be very helpful in that if you start to see a heterogeneous PET. Homogeneous PET, biopsy, follicular lymphoma. A heterogeneous PET, trying to go after the most avid, accessible, and safe lymph node, especially if there's a big difference in max SUVs throughout the body. And I think we've been in certain situations where we do one biopsy and then we may do a PET scan and we need to do another biopsy to rule out that transformation event. In this situation, Joe goes on and does have biopsies confirming that this is a relapse of his follicular lymphoma. There is no evidence of transformation. And so, as we discussed, we do believe that he is in need of second-line therapy for his POD24 follicular lymphoma. So what are the options on the menu right now? Well, we have some breaking news. We have an new FDA approval in the relapse refractory follicular lymphoma space, one that is relevant to this meeting. As you can see right there, the preliminary results will be released at ASH 2025 at Sunday at 10:15 as an oral abstract session. So let's go through the EPCO FL1 study, which evaluated the safety and efficacy of epcoritamab in combination with rituximab and lenalidomide. And this was a randomized trial compared to R² for patients with relapsed refractory follicular lymphoma. You can see here the eligibility was for those patients who had follicular lymphoma grade 1 to 3A. If your center is still doing grading, they had to have relapsed or refractory disease to at least one prior regimen using an anti-CD20. And in this study, the median number of prior lines of therapy was 1. You could see this was a 3-arm study. However, arm 2 was aborted very early in the trial. So arm 1, which we considered the control arm of R squared, was directly compared to arm 3, EPCO, dose B, R squared for 12 cycles. What should be known as kind of the highlights here is there was a statistically significant improvement in overall response rate, complete response rate, and a 79% reduction in the risk of progression or death. That being said, there were higher rates of grade 3, 4 neutropenia. Infections were observed in the EPCO R squared, but these were felt to be manageable and none were fatal according to the authors. So let's dig a little bit deeper. Same eligibility here. You can see what the arm A and arm C is in regards to the dosing schedule of EPCO R squared as well as R squared. For those of you with curious minds, the EPCO was dosed at 20 milligrams, but patients were allowed to enroll into the study with appropriate dose reductions of the lenalidomide to 10 milligrams if they had a creatinine clearance between 30 and 60, to my recollection of the study design. The primary endpoint you can see here is overall response rate and PFS by independent review committee. So let's look at the data. So EPCO R squared here, a very impressive overall response rate at 96%, R squared respectable at 81%. You can see here and drop all the way to the bottom to the complete response rate, which was 75% in the EPCO R squared and about 43% in R squared. Now, I alluded to that the primary endpoint was PFS by independent review, and you can see here the hazard ratio of 0.21 with an upper bound of 0.33. So that means that's a massive,
It's a stunning hazard ratio.
stunning,
Yeah.
right? You could probably drive a Sherman tank through these curves. Now, I haven't seen the curves, but I would imagine we're talking about tank curves, not Vespa curves, right? Where you're driving a Vespa. Are Vespas common in Spain?
Yes.
Yes, okay. So, so we'll see probably at this presentation what that PFS curves looks like. But whenever you're adding another agent, you want to think about the safety too, and they alluded to that. And one of the things with bispecifics, you're always thinking about cytokine release syndrome, neurotoxicity, and when are these events happening? So CRS events occurred over 3 step-up doses. Grade 1, 2 was at 25%. Most occurred just like what you would see with EPCO monotherapy at that cycle 1, day 15, our first dose of 48 milligrams of EPCO, noting that there is some changes in the EPCO dosing strategy, potentially in follicular lymphoma, all have resolved. If you're looking at hematologic toxicities, neutropenia was seen in 2/3 of the patients compared to about 1/3 of the patients in the R squared. Infections were more common from a percentage standpoint in the EPCO R squared versus R squared. But again, we always have to keep this in mind that there are patients who were on the EPCO R squared based upon probably the PFS that were more exposed over time to EPCO R squared than the arm who is getting R squared. And so I think that that's something that we have to remember when we look through toxicity from that standpoint. And you can see here fatal treatment emergent adverse events at 1% and 3%. Chan, what are your thoughts on kind of balancing the efficacy here with the initial safety?
I think that, well, one thing to point out is that unlike the monotherapy epcoritamab study in follicular lymphoma, the application of the drug here was fixed duration. So this is fixed duration epcoritamab. It is not treat to progression, which has implications for long-term safety because we know that many of the late toxicities, the infectious toxicities that come with indefinite bispecific antibody therapy relate to the long-term B-cell aplasia, hypogammaglobulinemia, and risk of infections, and that happen with ongoing therapy. So this is fixed duration. And you can see, as you've highlighted, that there is a price to pay for the improvement in efficacy here in both infections and cytopenias. They're both relevant. So that's grade 3 or higher neutropenia. And febrile neutropenia, probably more important than just neutropenia because that's okay. But the febrile neutropenia rate was 6%, so it's not insignificant. And the grade 3 or higher infections is 29%, so that's also worth noting that there is a price to pay. But, you know, for that PFS difference, it's stunning, and I think that we're going to compare this to another large phase 3 randomized study in a similar population in a moment. But I think that for Joe, I think, you know, he's probably going to be making a decision in favor of the experimental arm on this study. I think if he has access to that, then he will want the bispecific.
All right. Thank you for that. And setting me up also to now pivot to the InMind trial, which was tafasitamab lenalidomide plus rituximab in relapsed refractory follicular lymphoma. You can see this was a randomized trial. Also here, you can see that this was a double-blinded trial. So keying in on that the placebo arm then both the investigator and the patient didn't know if they were getting TAFA or not. And so I always find this very important when you start to look at safety here, because I think a lot of us think of tafasitamab as a well-tolerated drug, and this is a very good way to figure this out in a double-blinded randomized trial. You can see here the key eligibility inclusion included one prior line of therapy to an anti-CD20 monoclonal antibody. So again, very similar to what we saw in the EPCO-FL1 trial, and no prior treatments with R squared. You can see the dosing here, very similar, 20 milligrams from that standpoint of lenalidomide in both arms. Primary endpoint, progression-free survival. So here we do have a median PFS of TAFA R squared at about 22.5 months, compared to the placebo R squared, which is at 14 months. And these curves, you know, I would say it will be interesting to see the curves when we do see them. Certainly, these are wider than a Vespa, but you know, we will wait to see if it's a Sherman-like difference. So some further updates and key secondary endpoints looking at PET-CT. So in regards to follicular lymphoma, in the past we've often said the best predictor of long-term disease-free survival in follicular lymphoma is having a negative PET. And so you can see here that 49% of the patients in the TAFA R squared arm were complete metabolically, had a complete metabolic response, whereas about 40% in the placebo R squared arm. So even though those patients had a PET-CT, that difference was at about 10%, and you can see here the odds ratio in advantage for TAFA R squared comparatively to placebo R squared. Now, if you look at the overall response rate, so best overall response was 52% in TAFA R squared versus 40% in placebo R squared, and you can see the hazard ratio there 2 times more likely to have an overall response with TAFA R squared. What about toxicity? So again, randomized double-blinded trial, so we can pay attention very closely here that if you look at what the price you paid by adding the tafasitamab from a hematologic standpoint, really not much there from a neutropenia standpoint, and what's missing is anemia and thrombocytopenia, so I would imagine that this wasn't above 20%, so likely was very similar. This was done in the period of COVID-19, but here you're not seeing a high tick-up or a high discussion around grade 5 events that we notably had during COVID in the realm of follicular lymphoma, and often gave us pause when we were doing these clinical trials, literal pause mentally and pauses on trials when we were doing these bispecific as well as tafasitamab trials during the COVID pandemic. All right, so we're going to shift now to the personal experience of bispecifics in follicular lymphoma through the lens of Joe with Dr. Balonis, but let's go through what Joe was told. So he knew that POD24, as alluded to, was an adverse prognostic factor. It indicates a higher risk of death from follicular lymphoma, and it also implies likely futility of chemoimmunotherapy. So again, despite the SWOG 1806 data, which was keyed in on this patient population, where we really didn't see a lot of advantage of Obenlen against O-Benda or O-CHOP in regards to chemotherapy, it is something that we're signaling, I think, in the next generation of these therapies with bispecifics. And so really thinking about prioritizing non-cytotoxic approaches like bispecifics, like CAR T cells, and especially clinical trials. He's a working parent, though, and has a busy life at this stage and prefers to avoid hospitalizations as much as possible. But he prefers treatments with long time to next therapy and long PFS, and he wants to remain as active in his parenting as possible. So how do you treat Joe? Are you giving him EPCO R squared? Is he getting R-CHOP or SWOG 1806 O-CHOP because he received BR first? TAFA R squared or other?
Matt, I have a question for you.
Yeah.
Do you think that R squared is the new GEMOX?
Yes, I do, because there are several trials in the relapsed refractory follicular lymphoma space right now that are trying to accrue XR squared versus R squared. And I think, depending upon what we see at ASH, people are going to really start scratching their heads of, can we continue to accrue to those trials, at least in the United States, where we will likely have TAFA R squared, and we will likely have EPCO R squared.
Exactly.
All right, so 63% of us say EPCO R squared, 31% TAFA R squared. So what are your thoughts between the TAFA R squared, kind of EPCO R squared, knowing that we would love to have a randomized trial where these two go, head to head, Balboa versus Creed?
Better unlikely to see one. So it's interesting, isn't it? So we obviously haven't seen the EPCO R squared data in its entirety, and we will soon. But we've seen the hazard ratios, and you're trying to compare between different studies. What we have seen is the study design and the applications of therapy. And epcoritamab, of course, is a subcutaneous injection, so it's pretty quick turnaround for Joe. He can pop in, have his injection, and take off pretty quickly, and that's advantageous for him. He's got young kids, he's working, he doesn't really want to hang around the infusion center for ages. The TAFA requires 2 weekly infusions for quite a long time, and so there is a time toxicity associated with that, and the hazard ratio is not quite as favorable. And I think it speaks to the magnitude of the benefit we see with EPCO R squared that when I saw the InMind data last year at the last ASH, I was really impressed with the results of InMind. But now we have results from EPCO R squared, which actually makes InMind look a bit pedestrian by comparison, doesn't it?
Yeah, no, I certainly think it's putting R squared in the rearview mirror as more of a, does it play nice in the sandbox with what you're trying to add to it from a toxicity standpoint, understanding that it did have efficacy, and it was what a lot of us reached for in that second-line follicular lymphoma space.
Yeah.
We do have 2 questions here that I think would be reasonable to ask right now. How should we select patients for TAFA R squared versus R squared? We kind of went through that, but what has been your experience with TAFA R squared? Was TAFA as gentle of an addition to R squared if you've been able to use that?
I think that my experience of TAFA is as was observed in the study. It actually is a very easy and straightforward antibody to use, and you saw that there were not a lot of differences in the toxicity profile in the 2 arms of that study, and it was double-blinded, as you mentioned. Every now and then you do see a patient who does have an infusion reaction with TAFA, and when you see that in the context of a randomized study, you immediately know that they're not on placebo, which but that actually is the minority of patients. Like, it doesn't happen all that often, so it's...
One of the things that is the next question, this is a great question, is thinking about risk for transformation, right? Joe is young. Joe has had 2 symptomatic progressions of his follicular lymphoma. Both times, if I were seeing the patient, I would be looking underneath every lymph node block to try and make sure there's no transformation.
Yep.
So when you see TAFA-LEN data, when we are going to see the EPCO R squared data and TAFA R squared data, what does transformation events after therapy mean to you? If there isn't any, and their relapses are still follicular lymphoma, is that meaningful? Should we be asking that question? What does the third relapse look like coming off of these 2 drugs?
I think it's a very pertinent question to ask. I mean, I think that at the summer congresses, we did see a little bit of data about histologic transformation on InMind, and from memory, the numbers were small and it wasn't a huge signal either way. And we obviously haven't seen the data for the FL1 trial with EPCOR yet, but so I think it will be relevant. I think that antigen expression at the time of, if patients do experience transformation, do they still express CD20? Right. Do they still express CD19? Because obviously that has implications for your selection of subsequent therapies, be it another bispecific or CAR T-cell therapy.
And now we're going to get to the patient experience here, but I just want to park a thought in your neurons here around this opens the door again in follicular lymphoma for bispecific retreatment, because these are, at least with the EPCO R squared, it's going to be a fixed duration therapy, and we don't have a lot of retreatment data out there. All right, we're going to pivot here now to the patient experience, and Ms. Bolaños, please take it away.
Yes, thank you. Well, Joe represents the young patients that are still learning about their disease, are still learning about the treatments and the different impacts. So there are some health literacy gaps that we have seen according to the data. So this is important to keep in mind because more and more clinicians express, this terminology when they are talking and they are presenting different treatment options for shared decision making. So it's important to keep in mind, that not all patients understand all the terminology. You have just mentioned POD 24 and all those things that may not be here in the slide, but are still relevant. So only 17% understand what ctDNA means, and only half of the patients do not understand minimal residual disease. So all those things when you explain the PET CT scans, and it's important to be reassured that they really capture what is relevant for the information you are giving. They compensate these gaps by searching in internet, but they may bring correct or wrong information to them. So it's again important to clarify very well the terminology. Still, patients at that stage prefer to have shared decision-making with their doctors, and doctors remain being the preferred source of information. But if they are not offering enough information or it's not clear enough, they will rely on internet because they are quite active, they are young, they want to keep engaged, and that is part of their behavior. And it's important also to put that information in context for the novel agents and the treatment expectations that the patients have already expressed. And if we think of the data that has been presented, it calls my attention that there is very little mention to quality of life domains, not to say any, at all. So you mentioned fatigue, but no one has really expressed something about that. And he has expressed very clear that he wants to stay engaged with their work. They want to stay active. He wants to keep the parent role. According to our data, 21% of the patients never return to work, and it's not because they don't want to, it's because they cannot manage the fatigue. So, and he's 45 years old. You cannot think of a pre-retirement plan at that age, and you can estimate that there will be still a long road ahead for their patient journey. So it's important to consider, and I'm happy you mentioned all the risk markers and that you have been discussing, how the next treatment may look like, because the interest for these treatments is to have as long time as possible for the next treatment and to have the best control of the disease possible and reduce as much as possible the expected burden. You mentioned that when you have a subcutaneous injection, it can be quite easy and quite fast for the patient. They come to clinic, they get that, and they are done. That may not be completely true. You need to include also, do they need to have any tests before getting that medication? Do they need to have something, waiting time after receiving the medication? So when you present the administration mode, really needs to consider the complete time that the patients are going to spend at the clinic, from the time they arrive to the time that they actually can leave. So they can have, a very clear understanding in their mind, and not to have frustrations because their expectations were not really matching the real world experience. And this is quite interesting because we also did an analysis, and we are presenting a poster here from this data, and this is how treatment expectations, treatment attributes, preferences evolve from first line to where patients have their first relapse. You will see that although when follicular lymphoma diagnosis is presented, it's normally presented, as an incurable lymphoma subtype, there is still an expectation, even when you move across lines of treatment, that something new may come that probably will offer a curative option, although that's not the case right now. But patients rate high quality of life, as much as longer or improved survival and getting a remission or a response. So quality of life remains paramount for them in their decision making. And that's why it's truly important. And I want to call your attention that we see more and more often discussions about grade 3, grade 4 only adverse effects. What happened with the grade 1 and the grade 2? We need to talk about persistence of adverse effects and put that together to offer the context, because I may have a grade 1 or grade 2 that is truly persistent and never seems to get better, and that matters for the patient. When we move also to the first relapse, the convenience of the treatment start getting relevance in the treatment priorities. Reducing impact on the care partners is also important. The shorter treatment duration when you move to first line may not be so important, but for the next treatment, it will become more and more important. And the certainty about treatment results, believe me, half of the patients really look for that information, and they want to know about the evidence that it's available from the clinical trials data and also from real world. Tolerability of side effects, or the management of those side effects are also relevant for them. So it's important to include all that in your treatment choices presentations to ensure that the shared decision making is really considering all the dimensions that will impact their daily life. And this is just, kind of balance between treatment success and the human cost. When you talk about treatment success, of course, in your minds, you are thinking about efficacy and safety. That's the most important goal, and I agree. But safety does not always translate the same way to in the patient's experience. When you talk about infections, hardly mention did that infection require hospitalization, for how many days, how many days I needed to be off work, how many days I couldn't get close to my children, or because it was increasing my risk of getting infections and all those things. So the side effects, the burden on the caregivers, and the ability to function normally. And when I talk about functioning normally, it's your role, your parent role, is your capacity to stay engaged with your work. All those things are part of that functioning.
Very good. And I'm going to make a moderator audible here because somebody is in my brain asking questions here out in the audience. And so I'm going to ask this one right now because I was thinking the exact same scenario. So even though the R-squared EPCO data is very strong, it sounds like TAFA may be easier to use. So are bispecific antibodies a new CAR T cell with access issues? And will TAFA be the preferred community setting utilization, and bispecifics plus R-squared will be the new academic standard of care?
It's a provocative question, Matt, but I think that if we reflect back on the initial poll that we did about people's level of experience with bispecifics and their level of comfort, I think that as these agents become more widely used, we will see really widespread utilization across different disease treatment centers, including regional remote areas, because although the infection rate is a bit higher, we know how to manage infections. The cytokine release syndrome tends to occur early and predictably with the first full dose, and we're able to manage those. If you're in a place where you're far away, you don't have an ICU, or you don't have an emergency department necessarily, the first cycle can be given in an academic center, and then the remaining cycles can be given locally, and so the patient doesn't have to travel, and it's still safe. And so no, I don't think that's the case. They will be widely applicable.
Yes, no, I think that the irony is we've had 3 years to learn bispecifics in lymphoma, and probably the shepherd to bispecifics in the community is going to be tarlatamab in small cell lung cancer, right? Where every patient who has extensive stage small cell lung cancer will get to second-line therapy and have access to that. So I think that will be the push, the thrust, and then the bispecifics in lymphomas and myelomas will come henceforth because they will build out a more robust bispecific train of education and resources. All right, so let's now move on to third-line patient with follicular lymphoma here. We know that EPCO, Mosun, and Odro have data in third-line follicular lymphoma. You can see the study names here below. With calling out, 42% had POD24 with EPCO, 52% with Mosun, and 49% with Odro. You can see here very, very good response rates to EPCO at 63% achieved a CR. With Mosun, you can see here beyond 3 years, at 42 months, 64% of patients with single agent Mosun were progression free, and with Odro here you can see a high CR rate. What should be noted though with each of these single agent data sets was not a lot of prior lenalidomide exposure in this patient population. So again, we have these agents in third line, they're now potentially moving up, but when, if you choose to use like TAFA R squared, is this data truly relevant to that third line population who may or not have it? So now you can't really do a non-Hodgkin's lymphoma talk, at least on the B cell side and potentially in T cell side coming, to understand about third line CAR T cell, as we expected, the hopscotch of our bispecifics ahead of CAR T cell in the follicular lymphoma space with kind of the sequential other way in large cell lymphoma. Do we have enough data to know how third line CAR T cells will do actually with TAFA R squared or EPCO R squared, into the future?
We have very little information to answer this question. It's sheer speculation at this point, and we will be relying on future trials and I think largely observational data sets to answer this question. We have a little bit from the large cell world where patients who've had TAFA exposure can go on to achieve responses with CD19-directed CAR T. We know that after TAFA therapy in that setting, you often don't lose CD19. And obviously, we don't know if you need a whole lot of CD19 expression in order for axi-cell, et cetera, to work. So I don't think we know yet, but yeah, we'll see.
Yeah, I think stay tuned, and I agree with you wholeheartedly. I think the data is going to come through a lot of real-world consortiums, so grab your friends, do-si-do, and do some data digging, from that standpoint. All right, so what is the data of CAR T-cell in third line? So you can see here from the ZUMA-5 trial with axi-cell, all of these are incredibly impressive, response rates. When I talk about CAR T-cell, I talk about CR rates because that's where the durability lives, both in aggressive as well as in indolent lymphomas. Here you can see CR rates at 75% with axi-cell with a 5-year PFS of 50%. Again, kind of how long do you need to wait in follicular lymphoma? People will say 5, 10, until I retire, from that standpoint, but CAR T-cell does come with some safety concerns of CRS, or ICANS, as well as prolonged cytopenias.
Matt, can I ask you a question? Do you think that CAR T-cell therapy is curative in follicular lymphoma?
I think for a percentage of patients, the answer is probably yes, just like a percentage of patients that R-CHOP is probably curative in follicular lymphoma in the front line. You just have to wait long enough or have the data sets that are mature enough to see that plateau on that OS curve. But again, I'm reflecting upon, I at an institution where we have a database which goes back 42 years, right? So we can pull those curves, and certainly the curability of follicular lymphoma absolutely is there. And that was one of the first papers I wrote when I was 19 years old, asking the same question. So I think that, yes, in the front line and in the second line, and I think it truly poises a very interesting discussion that you get to have with patients, right? We say that potentially this is not curable, but do we say that because that's dogmatic, or do we, because that's what we were taught? Or should we be really looking at these data sets where we truly are seeing in third line potentially plateaus at 5 years, and as these therapies move forward, a la ZUMA-22, which is moving earlier lines in follicular lymphoma, and we have large cell lymphoma studies, that are moving into frontline therapy too.
I mean, the reason I ask the question is because the first thing you read in most textbooks or review articles is that follicular lymphoma is an incurable disease. And when patients read about it, they go and Google it and they read, oh my God, I've got an incurable form of cancer, right?
Yeah.
It's not a nice thing I never say that to people when they have follicular lymphoma because I just don't think it's the right way to start that conversation.
but according to the data we have, is how the disease, the diagnosis is presented to many. It's true that recently we listen more about functional cure possible with follicular lymphoma. That helps if you explain what does it mean.
Yeah,
Because functional cure is like, what's that? You know, can you please describe the functional, how it works? But I agree, you know, it's probably not the best way to start with because the patients panic and from that moment it's like, whoo, I don't listen anything else.
Yeah, I call it the wah.
And that's why it's important also present, you know, like written information that they can go and contrast and reassure what they listen. But yes, it's about being empathetic.
Yeah, terminology matters.
Yes, I agree. Function goes beyond just having a heartbeat. Functional cure from that standpoint. All right.
Yes, and here again, well, this represents, the one that represents the older patient, you know, you mentioned before that we need to keep, you know, like the independence truly matters for these kind of patients, you know, to keep a certain level of autonomy. Do they have option for a care partner or not? I don't think so. So you were talking about CAR T before, and I'm wondering, you know, but for CAR T, many times you need a care partner to get involved in that, and they truly panic about CRS. And what are the impacts of the neurotoxicities for their mental, you know, the cognitive performance. And according to the data we have, this is how is presented, you know, the number of treatment regimens, and we see that there are patients that have, we are talking about 2 relapses, but 32% present 3 relapses, so 3 or more therapies, 22%, 4 lines of therapy, 10%, 5 lines of therapy, 6 are 13 lines of therapy. I think you mentioned that it was diagnosed 10 years ago, so it's quite long. The accumulation of adverse effects that are still persistent matters. And here the important outcomes according to this age group is improved longer survival, of course, because you will have like longer time to next treatment. Hopefully we don't need that, but if it comes, and getting that response, getting the remission, especially for the symptoms control. But again, quality of life remains so high. So we need to keep that. And again, you know, the certainty of available treatment data. However, I want to explain that for these patients, for this age group, it's not that they are going to go back to check for the evidence, but predictability of what's going to happen when they receive that treatment. You know, getting the sense that everything stay under control is what really matters. So when you present even the evidence is how it's communicated to the patients. It's not about presenting numbers or percentages and curves, no, because that means really nothing to them. It's about how predictable my patient experience can be, how many times I will need to go to the hospital. Remember that these patients don't even live alone, so they are in a home, in a residency. It's interesting that 32% were given more than one treatment choice, meaning that the rest were not given, but only one treatment choice. And this may have different lectures, is that we may not have treatment that truly match the characteristics of these patients, or it's just because the age and the performance status and that protective role that clinicians many times adopt, you know, that of course you want the best for your treatment. And I think that this is quite well captured here. I'm happy that here it's included the fear of relapse, because as you move through lines of therapies, fear of relapse also comes higher and higher and higher, top of mind for whenever you talk about your next treatment and the symptoms you are getting. Never get to know if the symptoms are because of the treatment or because of the disease. And what it's important to know is that patients fail to report to their doctors their symptoms many, many times. And there are several reasons for that. Sometimes they don't want to bother the doctor. They know that time is a factor, but it's not because of that. It's because they don't want to bring things that they think that the doctor may not want to listen, because you don't normally, prompt those questions. So it's important to bring that questions into the discussion and to try to activate your patients, you know, to proactively ask for these things, how fear of relapse impacts your life, how fatigue impacts your life, to what extent you feel like anxiety, depression, mental distress, and how this may impact your treatment goals, needs. And yeah, and you want to complement with this, or?
Oh, no, I think we should probably move on in the interest
Okay.
of time and discuss the next patient. So I'm going to take over the next patient, which is an older patient with follicular lymphoma, really focusing on how we can address some of the toxicities in a more vulnerable population. And so we know that in order to deliver bispecific antibodies safely, we actually have to think about pre-treatment and things that we can do to optimize the risk of, or to mitigate the risk of cytokine release syndrome, hydration pre-medications, then how we deliver the therapies, and then monitoring afterwards. This is just a slide summarizing the strategies used to mitigate the risk of cytokine release syndrome. They're slightly different, but broadly similar for Mosun and Epcor, involving acetaminophen, into use for local parlance, antihistamine, and steroids, which are, you know, slightly different between the two regimens. There's a bit more steroid with epcoritamab dosing. So let's talk about a case. This is an older patient with follicular lymphoma called Wanda. She's 72. She's got relapsed follicular lymphoma. It lives in an assisted living apartment and has had 2 prior lines of therapy, bendamustine, rituximab, and R-CHOP, experiencing 5 and 3 years of remission after each of those lines. And she has been treated with mosunetuzumab and had her cycle 1 day 15 dose yesterday. Now, important to note, Wanda has got mild dementia. She manages her own medications. Her family visit her weekly, and we've checked the patient has a thermometer at home to check her temperature. The first 2 doses of Mosun were uneventful. There was no CRS. And she did receive dexamethasone, acetaminophen, and an antihistamine previously. Her daughter visited earlier today, and she was well, and she was instructed to drink more fluids. So what actually happens next? We get the on-call physician is notified at 7 p.m. that the assisted living facility called because she didn't turn up for dinner and was not responding to a knock on the door and a welfare check. She appeared confused, lethargic, disoriented, and she was unsure about whether she'd taken any additional medications at this point, and states that she cannot remember how to take a temperature. So the nursing staff at the facility check her temperature, and her vitals are summarized there. She does have a fever. She has tachycardia. Her blood pressure is 100 on 60, and her O2 saturations are 93% on room air. Her patient goals are to avoid pain, and she's fiercely independent and wishes to remain so as long as possible. So here is another poll for you. So what do you do next? Number 1, send her to the local ER for tocilizumab and potential ICU admission. Number 2, instruct her to take acetaminophen and monitor her at home. Number 3, send her to urgent care. Number 4, instruct to take dexamethasone and call if any worsening in symptoms. We're going to get some thinking music.
Thinking music. I like that.
Okay, so the majority of people have elected to send her to the local emergency room for tocilizumab, and I think that that's appropriate. We've got a few people suggesting acetaminophen and monitoring, and urgent care, and dexamethasone at home. Matt, what are your thoughts on these responses, or your personal thoughts on managing this patient?
Yeah, what concerns me was the altered mental status, from that standpoint. And it's, when people get fevers, like my father, he goes a little crazy. But we know that in his history. Perhaps if I had that history that, when Wanda gets a fever, she gets confused, but you still have that undercurrent that she's right in the prime time for CRS, but fevers can lead to confusion. But I also want to make the point that ICANS is very uncommon with bispecifics. And so the whole point about what did she take, and fevers do manifest as, an opportunity for altered mental status from that standpoint, just like a new environment does. So if you put her in the hospital with just grade 1 CRS, and at 3 in.the morning they're having altered mental status, is that because they have sundowning, or is that because they have ICANS? And so I think we're also at the end of the day internists and then oncologists. So we have to be internists and then oncologists. But I would certainly not feel comfortable leaving her at the care facility and just hopping some Tylenol on our decks.
Yeah, 100% agree. And I think that the take-home message from this is that CRS like this is not an outpatient management thing. You need to admit these patients and monitor in an inpatient environment.
You did mention to involve an internist. What about someone from geriatric care?
Yeah, so a geriatrician is an internist or a family practice doctor that specializes in elder care from that standpoint. And I think that, I'm always a proponent of multidisciplinary care. Geriatricians are really good at understanding the frailty of the individual. They are great 98% of the time, but what's the 2% when they're not? And a lot of times, fevers are in that 2%. And as we try to engage in advanced age individuals with this therapy, we have to keep that in mind.
So let's continue with Wanda's case. And we're really talking about after-treatment monitoring, and that's really what this discussion is about. I'm not going to go through this schematic in a great detail because a lot of this is familiar to us because CAR-T and bispecifics have been around for a while. But there are multiple aspects in terms of safety of bispecifics, including both cytopenias, risk of infections, neurotoxicity, which, as Matt has described, is actually relatively uncommon with most bispecifics, and cytokine release syndrome, which is actually the most common toxicity of bispecific antibodies. And fever, of course, is a prerequisite for CRS. And the mechanisms of CRS are summarized in the cartoon to the right. With severity ranging from grade 1, where you have a fever alone and nothing else, to grade 4, where you need ventilation and life support, essentially, ventilation, inotropes, etc. Fortunately, high-grade CRS is uncommon with bispecific antibodies. So just to summarize this in a tabular format, we've got a few studies here using EPCOR and Mosun. Of varying sizes. You can see that any grade CRS rate ranges from between 26 and 51%, mostly grade 1-2, with single-digit grade 3 or higher adverse events. And we know that CRS does tend to occur earlier on in the treatment cycles, typically with the first full dose of therapy. That's helpful because you can predict when patients are going to potentially get it. A little bit more about timing. With epcoritamab, when a 3-dose step-up is used, then the peak time incidence of CRS is actually cycle 1 day 22, which is when you get that first 48 milligram dose. In DLBCL, it's a 2-step-up dose, and you see it with cycle 1 day 15, so there is a subtle difference there. Important to note that in the epcoritamab experience, when there was an optimization cohort on that trial, where there was mandatory prehydration prior to the dosing and optimization of steroids, and actually reduced the incidence of CRS quite substantially. The onset occurs about, on median, 61 hours after cycle 1 day 22, and 88% of cases occur during cycle 1. With Mosun, you see a similar story. The first full dose, highlighted there in red, is cycle 1 day 15 with Mosun, and the median time of onset is 26 hours after cycle 1 day 15, and again, 2/3 occur during cycle 1. Median duration is 3 days. And so in terms of managing, this is a really broad brushstrokes here. We can pre-medicate We teach patients to monitor their temperature and to report it. If they have fevers, because we need to admit them if they do, consider steroids. We really need to be able to identify when patients need to be hospitalized, and patients and their carers need to know that. And as well as steroids, we would consider tocilizumab for patients with protracted fever or grade 2 or higher CRS, or if they have multiple risk factors. So another question for you to think about: do you do anything differently for Wanda's next dose of Mosin? We'll give you some time to think. Maybe a shorter amount of time for this one. So Matt, what do you think this is getting at?
That people who have antecedent CRS, you may want to do something different, either kind of with the monitoring phase of things or pre-medication.
Right. So it looks like most people agree, and certainly some optimization of pre-medication and/or potentially, even hospitalization.
Yes. I think there is some, with Mosin, in regards to the differences between the IV formulation,
yes,
and now potentially the
yes,
coming subcutaneous dosing strategy may allude to some differences in timing that we need to think about in the future.
Right. Exactly right. Okay, let's go on to infection management, because we know that this can be a potential issue after CRS. So there are a number of factors at play here. Obviously, particularly during early cycles, in order to mitigate CRS, patients get a lot of steroids, and important to consider the potential for infections associated with high-dose steroid use, like pneumocystis, and implementing appropriate prophylaxis to make sure that patients don't get that. There is an impact on T cells as well, even though this is not a T cell lymphopenic therapy. We do see some changes there in their ability to have the immune response against that. We know that we see cytopenias. We know that neutropenia is observed in a number of patients who were treated with these agents. And hypogammaglobulinemia is, of course, a common feature of patients with all B-cell malignancies, even at diagnosis. But as we continue to, by the time patients are starting to receive bispecifics, they've usually had, multiple prior lines of therapy, and they're often hypogamma going into their bispecific therapy. And it usually goes down on treatment, and I always monitor.
These are some of the lowest IgG levels that I've seen in my clinical practice. Have been people who are chronically exposed to the bispecifics, and I'm looking for a reason to give them IVIG in those situations.
100%. So let's look at this in a bit more detail, and you see the myeloma data in white above just as a comparator, but the rate of grade 3 or higher infections in the Mosin and EPCOR studies was around 14%. So it's less than what you see in myeloma, but it's still one in 6 patients or so, or just under. So in terms of mitigating risk, we need to think about things that we can do to optimize their risk of infection. And Matt, you alluded to the use of immunoglobulin replacement, and that's certainly an important factor. I think that educating patients about vaccinations, and I spend a lot of time talking to my patients about vaccinations. In fact, a lot of consults are spent talking about, have you had your influenza? Have you had your COVID booster? What about your shingles? What about RSV? Have you had your pneumococcal? And all of these things are critically important. And it's, I think, a big job for us it's a big job for us as hematologists, oncologists, to actually push this home, because in my practice, I don't know about you, Matt, but I've noticed that since the COVID vaccination discussions, there's a lot more vaccine hesitancy in general among our patient population, and that kind of hesitancy has spread to other things as well. And I think that we are in the best position to actually drive home how important it is for patients to get vaccinated and maintain that.
I think that is true, but also herd immunity actually matters, in regards to our patients who are on these therapies, just the efficacy of the vaccinations. You would love for everybody to be fully vaccinated before you give these therapies, to have some immunity during that low period of time. But when they're on it, there is that value of, yes, having it, but what is the efficacy of it? And so I do not only spend time talking to the patient, but I talk to talking to the patients or to the people who are going to be around that patient the most often.
100%. Yep. Completely agree. We talked about PJP prophylaxis already. That's super important, especially during cycle 1. And zoster, so acyclovir, valacyclovir. These patients are often lymphopenic, in fact always once you start therapy, and that's certainly a consideration as well. And then infection surveillance. So this, these are some nice data looking at, this is a poster which is being presented on Monday, looking at the kinetics of immunoglobulins over time from Mosen. I think Dr. Buddy is presenting this, and we've seen these in some of the longer-term manuscripts, and we know that with fixed duration bispecific antibodies, because therapy stops, there is time for recovery, and you can see that there is improvement in both IgG and IgM over time, because Mosen stops after 8 cycles if you're in CR and 17 cycles if you're in PR. And when therapy stops, there is a chance for levels to improve. So when you commence someone on IVIG, doesn't mean, or subcutaneous IG, doesn't mean that they have to be on it forever, because it's a nuisance as well, because they either have to self-inject every week or they have to come to the infusion center once a month, and that's time toxicity as well. So
but it isn't immediate. I think that's the that's the take-home point. Also, is that just because you stopped your bispecific doesn't mean that next month your immunoglobulins have recovered. We're looking at 6 months, before we start to see that trend upwards.
Yeah, absolutely. And I'm always like measuring serially and looking at their IgA and their IgM and seeing, has that recovered? And we always stop in summer, so that's about now for us in Australia. Opposite way around for you. Okay, immunotherapy, and this is B and T cell recovery following Mosen patients in CR. And just to highlight the fact, we talked about immunoglobulins before. We do see recovery of B-cell aplasia over time, but it does take time. If you can see there, we're looking at like 15, 18 months before we start to see B cells again. But it looks like the T cells come back slightly quicker, perhaps. And the T cell numbers remain relatively stable during therapy. So in terms of hypogammaglobulinemia, I think that it's important to monitor, because if you don't check, then you don't know. We talked about replacement, and we also, important to highlight that when you are giving people immunoglobulin therapy, it does impact the results of serology testing if you need to go and do that. And so if you want to do serology against things like EBV, CMV, etc., then you should do that at baseline rather than after you've commenced IVIG. So, Ms. Bolaños, I think we're handing over to you for this part.
Yes, in interest of time, I will keep it short. Just to be consistent with how I presented the previous cases, if we check for the key understanding gaps for these patient groups, although they have quite a lot of experience with their disease, it's more difficult to stay up to date with the terminology from newer novel agents. So there are understanding gaps for advanced therapy medicinal products to understand immunosuppression. There are still like 40% of the patients that do not understand well that terminology, and it's important to bring that concept together with the prevention strategies, what they can do themselves and what the people around them, because they are in an assisted living, must do to keep them protected. They are more likely, older patients, to fear about CRS, although it's not always presented with that terminology. So they don't really identify that, but they know they had fever, they know they had, and that's what really makes them feel like more vulnerable. Fatigue continues being the top one issue for these patients. Is the accumulation of the fatigue that comes part of the disease, but also part of the treatment, because treatments do not solve the fatigue. Is the opposite. it gets worse. Yes, so here what is relevant is the predictability, keeping independence, and how the clinicians can help to educate patients to reduce the level of fear, the fear of toxicities, and to provide not only allowed, the dialogues in the information, but written summaries that can be available for the people around them. And if there is a possibility to have a care partner involved, that's crucial, and with very clear information about what steps they need to follow, what are the red flags that they need to pay attention to.
Absolutely, right. So the last case is a long-distance patient, and Matt, you and I both have experience with this because for those of you, those who do not know the geography of Australia, so I live in Perth, that's on the west coast of Australia, and my state, which is Western Australia, is about, well, it's half of the country, so it's an enormous state. My longest, the patient who lives furthest away from me has to drive for 15 hours to reach my office. So long distance patients. So this is Trent. He's 63 and he's got relapsed and refractory follicular lymphoma with logistic challenges, and we're considering using a bispecific antibody for him. And he's a farmer, lives on a rural homestead in a healthcare desert. He is 2 hours from his closest critical access hospital and 4 hours from his closest academic medical centre and oncologist, hematologist. He was diagnosed 9 years ago, treated with bendamustine rituximab, and the first line, 5 years of response, then second line R-CHOP, 3 years of response, now presents with cervical lymphadenopathy, anemia, circulating lymphoma cells. His goals are to remain in home, and he's still working, he's a farmer, and he wants to remain independent for as long as possible. We kind of touched on this before. Please have a vote. Do you rule out bispecific antibodies due to his distance from medical care?
So does patients frequently fly to Perth, or how are, drive, fly?
Yeah, the government actually has an access, they subsidise the transport, so they can fly. Actually, it doesn't cost them anything, and they get accommodation covered as well. It's pretty good. How far away is your furthest patient, Matt?
8 hours.
8 hours.
Yeah.
That's quite a long way still.
But that's to the Colorado border of the northwest, Nebraska.
Yeah. So, no, that's good. So two-thirds of you think that we can still treat this patient with bispecific antibodies, and I think that's certainly true. So let's move on. So what are the specific factors with patients who are remote? There are... Oh, actually, this is your slide. I apologize.
No, they have unique concerns because really the distance is what shapes the entire treatment journey, not only now, but has shaped before as well. So they feel detached from treatment process, from care team. So when you talk about the symptoms, about the adverse effects they may experience with treatments, these are not physical, these are logistic challenges for them, because if they need to go to clinic, or even in the way going to the clinic and coming back home can be a disaster for them. And there is an added financial toxicity, there is an extra burden in comparison to other patients, and this comes from travel and also lodging if they need to stay close to the treatment center for receiving any treatment. So for these patients, also the impact of care partners, because they cannot travel alone. Most of the time they will need to travel with someone else to ensure that if something happens, someone is going to take the control, especially for the long drives back from receiving the infusion or the treatment, whatever the way of administration comes. And they struggle a lot about the side effects. Why if this happens to me? So when they balance efficacy and the promise of a survival or a control of the disease, they also bring at the same level the logistic implications for that. What it's going to take from me getting for that treatment promise. And believe it or not, distance may decrease survival opportunities. So treatment preferences are not necessarily based on what's the best treatment option for them, but what's really feasible from the burdensome perspective. And that needs to be discussed very, very well with clinicians.
I think it's particularly important in follicular lymphoma, where many of the treatments that we're offering don't necessarily have an overall survival benefit, right? So PFS advantage it's not everything. And exactly as you say, there are other very, very important considerations.
Okay.
Yeah, I think it is hard as a practitioner when you're offering patients to have equipoise. There's always, they're looking for that, what do you really want me to do?
Yeah.
Versus, and then if they don't choose what they really want them to do, then how do you as a clinician still massage that, like, well, did I do as good enough of a talk or discussion with them if they didn't choose what you were offering, kind of prioritization of first line, second line, third line options?
And to provide the patients with good management strategies, very, very efficient management strategies will be paramount again, because that allows them to stay in control of any symptom, any adverse effects that they may experience when they are far from the clinic.
Right.
Exactly right. Okay, let's move on. So in terms of CRS monitoring at home and relevant to this person who lives very far from medical care, we discussed this previously. Caregivers need to know about the symptoms, the expected timing. Patients need to have a thermometer. The pulse oximeters are actually quite straightforward to buy and use now, and having that on hand is very useful. Having a prescription for steroids if they're very long way from home, and it's obviously not ideal, but if you have dexamethasone sitting in your medicine cabinet, then that's something simple that can be done in a pinch. Considering the support network, family, friends, what extra things need to be put in place for vulnerable patients, and I have an amazing nurse practitioner team who are able to fully provide that holistic wraparound care, emails, phone numbers, and access to phone call support, and that's the communication tools as mentioned there. So in terms of bridging the gap, I mean, having a strong relationship with the primary care physician or general practitioner in these kinds of patients is critical, and having them understand what the issues are, making sure that, I think a lot of the time we assume that because we are doing this all the time that the information is filtering out into the community, but actually our colleagues in general practice really, they may have 1 or 2 patients with lymphoma, not 1 or 2,000 like we do, and they just don't know that fever can necessarily mean that you need to hospitalize that patient straight away. So educating them and being part of engaging them is actually really important. Telemedicine is super, super useful, and I use it a lot in my practice. I'm sure you do as well, Matt. And with the technology now, it's very easy to do. And clear written plans in the case of emergencies.
Yes, here is just to bring, what are the gaps in understanding the treatment options. So fixed duration treatment is the best understood term. And again, when you talk about other terminology that's not well understood, so ensure that you explain well in lay language everything to the patients and also to the people around the patient. When you talk about telemedicine, it's important to ensure that there is interactive. So it's not only a way for the patients, for instance, to report their symptoms or just to confirm that they are okay, and to have also strategies if they don't report back on time, what other person close to the patients can confirm or can ensure that they are okay, but also ensure that there is an interaction, that they receive back something, an information, what to do with that, or okay, we received that, it's okay. So ensure that telemedicine is bidirectional. And we already mentioned the logistic priorities, reduce the visits to clinic as much as possible, consider the financial toxicity, what strategies you can provide for monitoring, especially for CRS-associated treatments, and try to bring the timelines for the patients and the red flags very clear, explain, and the strategies to manage them. So you can really confirm that there are no misunderstandings.
Yep. All right, Matt, I'm going to hand back over to you.
Yes, as we wrap up this session here for future updates and future directions. So we heard about the EPCO FL1 data set here. So again, remember the primary results will be presented this ASH Sunday at 10:15 in an oral abstract session. I would imagine the room will be packed, so get there early. We also know that there is a phase 1b/2 trial of mosunetuzumab plus lenalidomide. I alluded to that this is where the subcutaneous dosing of mosun is coming into the soiree. You can see some early data here. Overall response rates 90%, CR 66% in a small 29 patient subset that continues recruiting. Here are some future bispecifics in follicular lymphoma, ASH items of interest. So you can see here is all GELF criteria created equal. So people are asking in the modern era, does GELF still matter? You can see here there's discussion on fixed duration subcutaneous mosun with maintenance therapy for patients with untreated high tumor burden follicular lymphoma, Saturday at 3:15. And then some evolving patient-reported value of treatment attributes in follicular lymphoma. And this is the insight from the Lymphoma Coalition 2024 Global Patient Survey of what you got a dip in the toe of the water by attending this symposium here today. So congratulations on that abstract. Looking at some new agents moving into the bispecific antibody realm here for development in follicular lymphoma. I'm still trying to figure out how to say this one, Survatimig. I'm going to go with that. But we know it's the Soundtrack B, the Soundtrack F1, and you can see some ASH presentations here for this CD3, CD19 bispecific. So a little bit different flavor of ice cream here. And then GB261, which is coming to us as a multi-center China, Australia experience in B-cell non-Hodgkin's lymphoma as well as CLL. And so with that, the invisible work of follicular lymphoma treatment, truly comes back to not only tracking appointments, adverse event management, the anxieties of the unknown of fear of relapse, scanxiety, thinking about transportation and time, the time toxicity, when it's out-of-pocket costs versus insurance and tracking the symptoms, and then also being a parent or caring for other family members with the disease. And then we can't remember that sometimes patients don't have the flexibility to clock in, clock out without consequences. So our key takeaways today is that in follicular lymphoma, bispecific antibodies are established in the third line, and that there are new second line approvals with durable responses at 3 years. Important toxicities to note, neutropenia, infections, as well as CRS. There is the outpatient options, and I don't think distance should preclude bispecific antibodies. It just may take a little bit more of logistical planning. And there are still unanswered questions that include ideal sequencing and combinations. And with that, we have some time for some questions here, and I'm going to use moderator discretion and hop up to the CMV question. So do you monitor for CMV with bispecific utilization?
No.
I haven't either.
I don't. In fact, I've used a lot of bispecifics. I don't recall seeing a patient develop CMV reactivation in my practice. You have a patient with unexplained fever and they've got blood culture negative and it's not CRS, then yeah, sure, you evaluate for it, but I don't monitor routinely.
So kind of along that line of switching back to efficacy of, is R squared now the new GEMOX? Do you really think that R squared adds anything to single agent EPCO, or if you were to put it in third line? Because a lot of those patients, as you saw, median was one prior line of therapy. Was it driven by line of therapy, or is it, should I be thinking about EPCO R squared in third, fourth, fifth line follicular lymphoma? Yeah,
look, it's a great question, and I don't think we know the answer because we don't have a randomized study addressing the question. But we know from the CD20 plus Len story that Len does seem to potentiate ADCC. And this is T-cell mediated cell kill. So it's a slightly different mechanism, but you are getting you're getting len plus R plus EPCO, and there are lots of unanswered questions about whether you need the R as well.
Yes,
right?
I think that's what the Mosin-Len will help answer here is what does the R really bring into the table besides probably a little bit of financial toxicity and potential just like immune system toxicity here.
100%.
Maybe it's not just vitamin R anymore. From that standpoint.
So, I mean, I would love to see novel combinations involving bispecifics with non-lenalidomide containing partners, and we're starting to see that now, Mosin Polar, et cetera, and Lotus-2 with, you know, new combinations of different antibodies, because lenalidomide actually is not a walk in the park to use, even though it's an oral therapy. It does result in chronic low-grade toxicities, to your point, Natasha, with diarrhea, fatigue, neutropenia. All these things can be pretty rash, annoying, right?
Yeah, I often say there's usually a right dose of lenalidomide for every patient. It's just not commonly the starting dose. So they will over time find their groove. You know, and so as a practitioner, finding the right dose of lenalidomide is incredibly important, and being mindful of the renal dysfunction. Last question, last minute, a little bit about CR rates and curability. I do think that CR rates is the path to cure. So if we see high CR rates, that gives more patients opportunity for duration of CR, and I think that's where we will see the plateaus on the curve. And with that, we will end promptly at the bottom right here to earn your credit for attending today's session, either in person or online. It's right there on that QR code. And thank you very much for your participation.